Hi, this is Fernando Gomez Sancha, and today I am presenting an interesting case of a man that underwent GreenLight vaporization of the prostate 12 years, I think, earlier, performed by me. And he experienced a deterioration of the improvement that he originally had when we did the GreenLight vaporization. So this man and I were thinking what to do, and he was happy to be operated again, trying to improve and to get back to the excellent quality of life he got with the first treatment. But this time, of course, we want to make a definitive treatment. And this is a very nice demonstration, a very nice case where you can see how, despite the excellent look of the posterior aspect, which seems that doesn't need any treatment. No, we see anterior tissue that we want to remove, but one would say the posterior is okay. Why touch that? But I'm going to show you how the En Bloc approach will find that there is more tissue there than we thought there would be, and how the En Bloc approach is excellent for the redo cases. Okay, here we just have to be careful with the sphincter. I think we could have gone on even a little bit higher, but I was trying to be careful and preserve the mucosa anteriorly, so that when the sphincter closes, the mucosa will help the sphincter carry out its role of closing in a watertight fashion, so that the patient will have perfect continence from the first day. We are using the 150 watt Quanta system at settings of 2 and 50 watts. And using virtual basket, which is this mode of emission, this pulse modulation that emits 2 consecutive bubbles, the double bubble that provides excellent dissection properties as the classic holmium, but much improved first pass coagulation. And you're going to see in this video how we didn't really see bleeding almost at any stage. All right, so initially it looks as if there is not much tissue posteriorly, but I have already quite a big experience on redo cases, and often this is misleading, so you have to keep looking and stick to the method, stick to the technique, and then we will start seeing that there is more tissue there than we would have said or would have guessed by the look of the endoscopic image of the capsule, right? Here I had some difficulty with the legs, so it was not easy to reach where I wanted. So sometimes we have to do that by being patient, and at some stage we manage to do what we want. So that's the posterior plane. You see, trying to come upwards and do the early apical liberation. So here you can see how we can go around the adenoma, initially trying to release a little bit of the posterolateral aspect, because otherwise it's going to be difficult to release the apex completely. So we need some mobility of the apex. Here, for example, I recognized, you see, that I was leaving some tissue. So with HoLEP you have to evaluate what you're doing constantly. You have to be present in the operation and study the information that the camera is sending to you, checking how the tissue looks like, and there you can start seeing how there is a big amount of tissue posterolaterally that wasn't removed in the first operation, or probably we left a small rim of tissue there that has grown over time. So if we want to provide the patient with a definitive result, we have to go all the way down to the interface between capsule and adenoma, and do the best possible job. But here I was trying to release the apex. It's nice to mark the white line, you see, because when you have to work there, the fact that you see white tissue that has already been coagulated tells you exactly where the landmark is. So you don't want to damage the sphincter or the sphincter's mucosa. And this careful way of going around the apex very carefully. Initially here, you have to follow the plane, you see. And when we are right at the apex, below the sphincter, you have to cut more horizontally. And then, of course, as you have protected the sphincter and you have already done this horizontal line, you see here, for example, horizontally, you go inside, so the sphincter is left behind, and then you have to go up to look for the uppermost possible plane, even apically. So here you see, here again, we can cut to detach the sphincter from the apex of the prostate, but very fast, once we have done that space, we have to try to go back and look for the good plane so we can remove the adenoma entirely, also in the apical level, right? So it's a matter of, again, checking what you're doing, seeing if the plane is satisfactory, following the line, but here anteriorly, going up, 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 until you get to the proper plane, and this way you won't leave any more anterior tissue. This is exactly what we want to remove in this patient. So here you can see that this pulse modulation provides excellent cutting properties, excellent dissection properties, and excellent hemostasis as you go. So first pass hemostasis is really good. So you can only focus on the dissection and what I'm talking about, the quality of the plane that tells you if you have to go a little bit deeper or if you have to go closer to the adenoma because you're deepening in the capsule. At some stage, we will see a very thin capsule area. Here, for example, you see you don't want to follow that path. So I make a mental note of that and continue with the operation. But when I go back there, I will have to correct the plane, right? So it's important to advance in the operation. Every moment you want to do something that is going to make things better. And one thing that you have to understand is that as you release the adenoma from the capsule in more places, more circumferentially, it becomes more mobile. There's freedom, there's mobility, there's better access, So don't get stuck in one place. Go around the adenoma, because as you gain mobility, as you gain access, things are going to get better and easier. And, that's why I think this technique is so fast and so nice, because it moves around. You have one line of attack, which gives you the general idea of where is the capsule and the separation with the capsule, with the adenoma. But of course, you have to tailor the aiming of the beam. You have to aim at certain moments right at the line of attack. In other moments, you might decide to fire a little bit outside of the line of attack and sometimes inside. Mostly, I would say that the first half of the operation, you have to fire against the line or a little bit outside. And as you continue with the having to adapt to the curvature of the adenoma as it, for example, here goes down, you see the plane now, it's not straight anymore, it has to go down. So you have to point your fiber downwards if you want to get to the bladder neck. So you have to be very vigilant, see the tissue information that you get as you dissect. If it looks as if you are too deep in the capsule, then you have to correct and get closer to the adenoma, and the opposite. So this is the only, of course, you have to control the distance of the fiber with the tissue to get the desired effect. And also you can control the speed of movement. So the displacement from one side to the other, or up or down, you have to tailor how you're going to use the energy. So, when people ask me about settings, what settings do you have? It seems like the laser is going to do the job. It's not true. The laser is going to emit some energy, but you have to adapt to the settings you're choosing so that they do what you want. So, of course, some people prefer some settings, but the same settings of the laser with different strategies of manipulation of the fiber can probably give different tissue effects. All right, so it's not the setting only, it's the surgeon who is going to decide what to do. Here you can see that occasionally my fiber touches the tissue, and this is because this is a very fibrous prostate. It was operated before. There's some processes of fibrosis, sometimes a little bit hard tissue, so sometimes the no touch doesn't cut it, and you have to do a little bit of contact. Of course, always judging, where do I want to go, what is my plane, and how I'm going to fire the laser so that I get the desired effect, knowing what I know and what I keep learning every minute about the geometry of this particular prostate. So here you see how the fiber gets closer to the adenoma to try to avoid. And here, for example, we want to correct the plane. We don't want to continue down there because that would cause a perforation. But you see, as the movement of the fiber is quite fast, we never penetrate too much in the capsule. So it's difficult to go deep. So the moment we see that we are getting a little bit deep, then we correct the plane. And here you can see how the fiber stays up very close to the adenoma, and the position of the fiber is corrected with every excursion of the fiber. You see here, I'm going at this level. As I go to the other side, I go up a little bit. So constantly adapting to get the effect that you want. I think it's a very, very demonstrative case of how the En Bloc technique with early apical liberation works really well for these redo cases. It also works extremely well for the virgin cases that never had an operation before, but in these redo cases that sometimes have very awkward prostatic fossas and synechias and so on, you don't even need to go in the bladder first. You can perfectly start at the apex, and then you will enter the bladder and watch the bladder and do what you want. Here, the laser stopped briefly. We were operating in one of the operating theaters that is quite small. It was very hot in the operating room, and I think the laser overheated for a moment. So we stopped for a moment and let it cool down a little bit, and then we continued. I think this En Bloc technique is very demanding for the laser because we are firing constantly. There's very little pausing time. Most of the time we are lasing and operating. Of course, you have to take your time to see the anatomy, to decide what's coming next, but most of the time I would say we are lasing almost continuously, and that must be demanding for the laser. I have to say that most lasers I use can stop sometimes. So I haven't found a laser that doesn't ever stops. Sometimes you have this brief pausing time and then you continue with your work. So there we are, finalizing the posterior aspect, connecting it with the lateral aspect. You see, following this technique that I was mentioning before, where the fiber gets very close to the adenoma, and as you progress, you get closer. You see one excursion to the left, Now the fiber goes up a little bit and then to the right, and then the fiber goes up a little bit more and then to the left again. You know, that's the dynamic of the dissection of the posterior plane. The yellow tissue could be adenomatous, so that's why I was considering what to do. But sometimes it's just too little tissue. It's already coagulated. Probably it will fall off and come out with the urine, as it is a necrotic little piece of tissue, very little. If it was a nodule, we would go for it and try to take it out, no matter the cost or no matter how thin the capsule gets at the end. But if it's a minor millimetric yellow thing that is all coagulated, maybe I wouldn't care about it. So here we are coming under the adenoma. That's a vaporization of a yellow little piece, you see. So we don't, when you leave a little piece of yellow tissue, you might as well stop for a moment and coagulate. That's the 6 o'clock bladder. There is this attachment here. You see, so as you progress with the operation, you start understanding the shape of the prostate a little bit better. And then it's a matter to use the tool you have at hand to get the effect that you want. The bladder neck in operated patients, it's usually very, very fibrous, very stiff, and sometimes it might be a little bit more difficult to cut it. It's very important to learn to position yourself properly with your camera so that the line of attack is always in the middle of the screen and you can see adenoma in one side and capsule in the other side. This is what helps you judge if the plane is correct or not and what you have to do next. Here, see, we had a little bit of difficulty accessing that part. Here, it's not good enough. So position yourself properly. Try to recognize the tissue, where you are, in what position, and what is the direction of the dissection. And then, of course, continue. You see, adjust to the curve. So in your mind, you know the shape of the prostate, the shape of the curve, and you can, with all that information in your head, you can progress in the operation, using the tool safely, judging the tissue constantly. So I would say it's a meditative state you enter when you start operating with holmium, because your mind is and your cerebellum are working, in conjunction to help you carry out a task, understanding and integrating a lot of information that you get from the tissue, that you get from your hands, that you get from the image, to try to complete the operation. That's cutting attachments to the bladder neck. You see, it's a very tough, very fibrous bladder neck, so it takes a little while to cut. But I have to say, with pulse modulation, cutting of holmium has been enhanced so much that it is now much faster, much more satisfactory than it was before. So I would really recommend, if you're going to start HoLEP, to get one of the pulse modulated lasers, because you don't worry about hemostasis so much. You just worry about anatomy and finding the right plane, and it becomes a very simple operation. And I'm convinced that you have better chances to learn if you have a pulse modulated laser than if you have a conventional holmium. So here we are. That is now checking for the UO. There it is. And there it is. Okay, so the case is nearly finished. And I hope you are convinced, like I am, that an en bloc approach works really well for redo cases. We have published a number of them already in the YouTube channel, and they're always interesting. I love these cases. This is probably my favorite case because they're always challenging, and I always marvel at how much more tissue we can take out after the previous surgery. Here we are changing the cystoscope for the nephroscope, so we can start with the morcellation. I cannot insist enough in how important it is to have a trained team that can help you properly so you can be fast with the changes. Now, in this change, for example, we changed the cystoscope for the nephroscope, but the morcellator had to be ready and handed to me at the right moment. The pedal that I was using for the laser had to be changed for the pedal that manipulates the morcellator. So you see, the teamwork is paramount in this case. Here you can see it's a fibrous prostate. It's a little bit difficult to chew by the blades. And again, here the methodology is always the same. The adenoma stays on top. The blade is in the middle of the image, in the lower part of the image. And on both sides we can see a triangular shape that is looking mostly black. If it looks pink, it means that we are getting too close to the bladder. So that is my safety tip. Keep the morcellator a little bit inside the bladder. Don't be afraid to push it in 2 or 3 centimeters, because if you keep the morcellator too close to the lens, then the tissue won't let you see these little triangles on the sides of the blade that tell you how far you are from the bladder wall. So morcellation took place quite fast. This morcellator can take 10, even 20 grams per minute sometimes. And on average in our hands, it's about 11 grams per minute. So this was a fast morcellation. Patient had the catheter removed the next morning and went home without any trouble. And I hope you enjoyed this video from the channel. I'm getting very good feedback from many urologists around the world that enjoy these operations and tell me that they learn a lot. And I'm very glad to share this and keep sharing this. Thank you very much for your attention.